Okay, so where are we now with Transcaval TAVR in 2017? Here are my disclosures. So, quick case. That's 2017. This is a couple months ago, but 80-year-old, has some risk factors, intermediate risk, annual supports a 23 valve. Here are the measurements. Just look at the red: 4.5 by 8.6 for the femorals, 5.6 by 6.9 for the subclavian, 5.4 by 7.1 for the carotid, and we do Caval Imaging, and they have Caval Access. So my question to you is, you don't have to raise your hand, but think in your mind, those are the measurements. What do you do at your institution? I mean, these are your choices. I can't think of much more. Some push the femorals, some still do intrathoracic access, and some have moved towards extrathoracic access. So back in 2013, I like to say circa 2013, because that was like the dark ages of TAVR. I'm just kidding, actually. But this is what you had, right? The sheets were big. So let me throw out this question. If you can't go femoral, is TAVR actually better than surgical AVR? In other words, if you're going to use intrathoracic access, is it better? Do we have data to support that? Now, I don't have access to all data, but in a randomized trial of Partner 2, when you broke it down, remember this was a stratified randomization, so you said up front, if we're going to get randomized to TAVR, we're doing this intrathoracic, and then you got randomized. So there's no differences in baseline characteristics, give or take, with a little bit of caveat. And the fact of the matter is, in this cohort of patients, I don't have access to the Caval data. Maybe Jeff could comment on that, but the fact of the matter is, in this segment of data, there's no data that intrathoracic is better. You might as well just put the valve in. That may be chance, maybe not, but it's something to think about. So what about these three access options? So let's let people say, okay, carotid, subclavian, Caval. So which of these has been the most rigorously tested? I didn't ask which is the best. I'm not going to comment on which is the best, but which has been most rigorously tested? Again, I don't have access to all data, so we can throw it up for questions later, but this is really what is, for the most part, talked about. In the subclavian world, there's the Italian core valve registry. Keep in mind, this is the TVT registry equivalent. This is prospectively collected data, but it's voluntary, site reported, no adjudication, no systematic imaging, things like that. Data looks pretty good. I did see some abstract data from the pivotal US core valve that looks like subclavian can be equivalent to transfemoral. Again, I haven't seen the peer-reviewed manuscript yet, but the fact of the matter is there probably is more data coming on subclavian access. I don't show this picture to bash any access method. I'm just saying they all have complications. I think if we say that any of these access methods don't have any complications, I think we're being a little bit silly. Transaxillary, of course, is moving the incision to none and laterally, and I think Jamie McCabe has been pushing this, and it's really a great access method. The question is, will we have enough data to say that it's equal? So how about the carotids? We do these also. It's not a carotid endarterectomy. It's a pretty small scar. It's pretty well tolerated. These guys are home on day one also. And here's the French registry to support the use of carotid access, about 100 patients. Again, prospectively collected data, but voluntarily site-reported, like the TVT registry. There's no site monitoring, no adjudication. There was no systematic neuro follow-up. There were no CT scans. We looked at our transcarotid access, though, in our own institution, and it looks pretty good. I mean, it looks pretty equivalent to transfemoral, so I think carotid's out there. But you're looking at a couple hundred patients either way. So how about Caval access? Well, just to me, making it the most transfemoral-like should make it the most easiest to tolerate for the patients, and I think maybe we can improve outcomes that way. So what did we do to collect data for Caval access? We did do an FDA-approved IDE study of 100 patients. The only differences I would point out, though, it was prospectively collected data, just like those other two, but it was site monitored, it was CEC adjudicated, and we had systematic CT follow-up in everybody. So pretty rigorous testing. And the fact of the matter, it works. And this is nothing new. This data was published last year. All in one case we got across, and in all in two cases we were able to close with the intended closure device, and survival was no different than any other access method. But I think this is important to talk about, which is the bleeding, because that's what everybody worries about. Well, the only trial that I think is reasonable to compare it to, although I do think you can compare it to now the core valve intermediate risk registry as well, but at the time that we did this study, the Partner 2 study was the only other adjudicated CEC monitored, so site monitored CEC adjudicated trial. And if you look at the bleeding in the intrathoracic access for partner, it's high. And if you look at the transcaval, it's not quite as good as transfemoral, but it's getting there. And this STS score in our population is pretty high. So what's really happened in transcaval? It now has a life of its own. I don't have anything to do with transcaval anymore. This is these are proctors that go out and monitor and proctor these sites. And there is a big state, by the way, on the bottom of this map for these guys in the front row here that has no pins on it. Just pointing that out. But nonetheless, every day there's a new pin that gets added to the map. We looked at all three of our extrathoracic methods, transcarotid, transcaval, and compared them to transfemoral at our own institution. And actually, for the most part, they're all the same. The transcavals did have a slightly STS score, but there is this higher transfusion rate that we see. And interestingly, is we don't really know why, because you don't see any blood in the CT scans in the RP space. But nonetheless, not sure if it's a patient population selection issue. We just can't figure that out. But outcomes at 1 year with all these access methods are the same. So in this particular case, we went transcaval, and the only reason I show this case is, the burn was fine, and putting the sheath across was fine. This happened to be a core valve case, and so the valve goes in okay. And this is not my case, but actually during pullback, they actually pulled a little too hard, and the device pulled through. And we have a buddy wire in, but if you can see in this picture, they shoved up the catheter a little too quickly, and it didn't go over the buddy wire. It just rode up in the IVC, so they lost the buddy wire. So now, just so you know, there's nothing across this patient's caval tract, and they were fine. Here's a picture they took. That's not a simultaneous injection. That's flow going across and over. Patient was hemodynamically stable, and they called me up in clinic and said, what should we do? We don't even have a buddy wire anymore. Should we just leave it? And the patient was doing fine. And that's, again, this concept that the pressure in the RP space is higher. So these people do fine with those two holes as long as you have both holes. So I said, well, let's just cross it again. And if you don't believe that there's still a hole here, this is just an Agilis catheter being dragged down in the IVC till we find the hole in the IVC. And then we use the pigtail that was there to line it up again. And then this is just a BMW wire. And if you knock, we're just going to twirl the wire and move the Agilis catheter until it finds the hole again. There's still a hole there. The hole didn't go away. So they went ahead and we closed it. And this time, the device is in the right spot. Patient did fine. Half an hour of no closure device. Stable hemoglobin, goes home on day 2. So I think you got to look at all these access options and really be critical and think about what are they really doing in terms of things that are important to you. Length, important to the patient, bleeding, length of stay. Do we have outcomes to really support the use of that access method and costs and things like that? These are all important. And I just think as you move to the right side of this graph with the axillary and the carotid and the caval, I just see more greens and yellows. And so to me, it makes sense to move there. So these are my thoughts on it in 2017, that there's still the 6% complication rate from transfemorals that we just can't seem to get under. There's unlikely to be a randomized comparison of these extrathoracic methods, but they appear to be better than the transthoracic ones, and I think having expertise in those methods can improve outcomes. And my last statement is transcaval is not just for breakfast anymore. I mean, it's not just a last-ditch effort. There are sites out there that are choosing to make it their primary alternative access method, so learn to burn, and we'll open it up for discussions. Thanks.
I have a question for you, Adam. At your place, a patient is medium risk, but they don't have femoral access. Do you go to surgery?
No.
Do you go alternative access? Do you go cable? Is cable appropriate for medium risk? Your comments.
So we do. I mean, we look at transcaval and transcarotid first. Those are our preferences over subclavian, just because just don't really like being on the left side. That's just a personal preference. But we have done them all. And those will still go to TAVR, and they'll go Caval Access. Most of the intermediate, on the lower side of the intermediate risk, have femorals, right? It's really a complication of, because by definition, the PADs are already bringing your risk score up. So it doesn't, happen all that often. But these patients do go to Caval Access. And we looked at our data, I tell people all the time, there's the crack and pavers and to push the femorals at all costs, and I tell them, I'm not sure why you need to do that. These other access methods allow you to do it. And when we look at our TVT data, our vascular complication rate's now less than 1%, because I don't push the 4.5s and the 5s and the heavily calcified ones. I just move on to something else, and they're home in the same amount of time, so it doesn't really bother me.
So have you ever seen a closure device related complication a year or two down the road?
So we've CT'd all the people in the ID study, got 1 year CTs, and they all look fine. There's been no delayed complications, and all the action happens up front, and if it looks good, I mean, they say aorta doesn't move, they don't twist, there doesn't seem to be any issues, and now that we don't span it with a VSD device, there aren't even any forces on it, so we've seen no complications, at least out a year. I mean, we didn't CT people after that.
I mean, has anyone who uses a PDA device for congenital seen a complication from the PDA device, long-term follow-up? I haven't. Have you seen, Ted?
No.
Because, I mean, that's basically what you're doing, using a PDA device to close an aortic venous connection.
Highly similar to a PDA itself.
Highly similar,
yeah, so,
right.
Right, and I think PDA occluders in general now are used all over the place, and I haven't seen reports, I'm sure they're out there, but
Right.
fairly benign device compared to some of the larger devices.